Good morning and good afternoon, everyone, and welcome to this event on the power of AI to ensure equity in healthcare. It's a pleasure to be co-hosting this event today with George and our friends at Community Jameel. I'm Tariq Khokhar, and I'm the head of Data for Science and Health at the Wellcome Trust. Our mission is to support science to solve the urgent health challenges facing everyone. And we simply won't achieve that mission without the responsible use of artificial intelligence and machine learning systems of the sort we'll be hearing about today. We're all more aware than ever about the health inequalities across the globe, those unfair and avoidable differences in people's lives and outcomes within and across societies. This is a complex problem. Looking at SDG data from the WHO and the World Bank, we can get a sense for what's going on. Countries like the UK and the United States have about one physician for every 300 people. Now, that may not sound like a lot, but when you compare it to countries like Pakistan, Zambia, or Egypt, the numbers can be as few as one doctor for every 2,000 people. We clearly have to invest in the human capital and infrastructure of healthcare. But we also see the opportunity here for advanced digital technologies like machine learning systems. And that's leverage. Leverage to give healthcare professionals tools and capabilities to increase the volume, quality, and types of care they can offer. So here's the question I hope we're all thinking about. How do we build and deploy these systems so they reduce inequalities and don't simply amplify the status quo? At Wellcome, we have the privilege of talking to brilliant teams like Regina's all over the world, and we hear many different answers to this question. For instance, we have to think about bias in training data or the diversity of the teams collecting this data and building these systems. Or maybe we have to think about better measures of success. After all, technical performance in a computer model is very different to a clinical evaluation of patient outcomes. Or maybe we really have to build public and patient trust and participation in the design and regulation of these systems so they'll be trusted by patients and professionals alike. Or maybe what we really have to do is think about distribution and business models for these technologies and both opening up and growing new markets for them. Like the problem, the answer is complex. We must think about all these issues and many more, and we have to appreciate that no one field or discipline working alone will have the solution. We must come together as a community with a shared interest in using data science to achieve health equity. And I'm so pleased to see this community coming together today. So welcome again. I'm delighted to have a panel of such deep, broad, and multidisciplinary thinkers, and I'm excited to hand the floor over to George. Thank you.
Thank you, Tariq, and thank you everybody for coming here in London, in New York, and online for this gathering on the sidelines of the United Nations General Assembly. Thank you to our co-hosts at Wellcome, and of course the Jameel Clinic, Regina and others, and of course Freuds for helping us to put on this event today. I'm George Richards, and I'm the director of Community Jameel. We're a global organization tackling some of the world's most urgent issues using a pioneering approach grounded in evidence, science, data, and technology. At Community Jameel, we believe in the power of artificial intelligence to transform healthcare. And we are immensely proud to be the co-founders with MIT of the Jameel Clinic, the revolution unfolding at the intersection of AI and healthcare, of computer science and biology, has the potential to advance early detection of disease, drug discovery, personalized treatment, new medical devices, and far beyond. But what excited us most at Community Jameel in 2017, when we began discussing with MIT how this might take shape, was the potential of the Jameel Clinic and AI in healthcare more generally to challenge the inequities of healthcare treatment among the poor and the marginalized around the world. In the United States, for example, where the Jameel Clinic's MIRI technology is improving outcomes in detecting breast cancer by achieving equal accuracy for Black patients as for white, where results historically have been much worse for Black patients because of biases in majority white data sets used to train machine learning algorithms. This is one example. But for Community Jameel, with our roots in the Global South, What really sparked our imagination was the possibility that artificial intelligence could address the unequal healthcare outcomes in the Southern Hemisphere compared to the North, some of the points that you mentioned, Tariq. In other words, that the innovations in AI and healthcare pioneered will lead to a leap forward, delivering cost-effective solutions to early detection of cancer, or discovering that inexpensive, regulator-approved medicines could tackle preventable diseases, and so on. This year, the Jameel Clinic, with support from Wellcome, is embarking on a research program to implement machine learning tools in real-life clinical experiences through networks of global hospitals. The hope of this initiative is to develop procedures for safe and effective deployment of AI tools in specific clinical contexts and refine AI tool development globally. So we can move towards more equitable health outcomes, not just in the US and the UK, but across the globe. You will hear more about this from our distinguished panelists, but before that, a short video as a prelude for the discussion that will follow. Thank you.
What are health inequities?
So how are we going to beat this novel coronavirus?
We are already working at the full capacity, rather double of the capacity.
Health inequities are systemic, ingrained, and most importantly, unjust barriers.
What is a pathway for this patient which would improve their healthcare outcomes?
In my lab, we're using the tools of artificial intelligence and synthetic biology that could help us fight the current pandemic. Machine learning is turning the traditional model of drug discovery on its head.
We have techniques to understand something new about biology and see how they are changing discovery.
Welcome, everybody, to this exciting event that we're having today. And I want to thank George Richards at Community Jameel and Tariq Khokhar at Wellcome again for your inspiring remarks. I'm very excited about the panel today, and I'm here from the Lancet, where I'm a senior editor based in New York. So welcome. UNGA in particular is very exciting this year because we are able to bring people together, different time zones, different places, to really talk inclusively about this very important topic. So today I will very briefly announce our panelists. One of our panelists is Regina Barzilay. And Regina is at the School of Engineering, where she's a distinguished professor of AI in health and AI faculty lead for the Jameel Clinic. We also have Dr. Edson Amaro Jr., who is the head of the Big Data Initiative at the Albert Einstein Hospital in Sao Paulo, Brazil. Dina Katabi, professor of electrical engineering and computer science at MIT, director of the MIT Wireless Center. Najat Khan, who is seated next to me here and is the chief data science officer at Janssen Research and Development. And Ziad Obermeyer, who is an associate professor at the University of California at Berkeley. And I encourage all of you to have a look afterwards at some of the incredible work we're doing. The panel today is very distinguished, from the heads of science divisions and initiatives to MacArthur geniuses. So we're really very honored to be here. So welcome, and let's jump in. I thought I might ask the panel first, and I'd like this to be a very interactive discussion. So please just raise your hand if you have something to say to the panelists. Jump right in. I'd like to kick off the discussion by asking you first to tell us what you think AI can concretely offer people everywhere to make this significant reduction in inequities that would really be achievable in the next 3 to 5 years. We don't want to just do talk here. We want to get at concrete action, and we want our audience to hear what needs to happen in order to get there. Who would like to start?
I'm happy to jump in. Being live actually helps. Thank you again. It's great to be here, and thank you, Miriam, for the introduction. You know, I think the potential for AI, and not just the potential, but the impact that's already happening. So I want to focus on both aspects a little bit, because I think sometimes we focus on the former too much. So let's think about making a medicine. You want to be able to figure out what's the right target, what's the protein that's actually causing the disease, all the way to what's the molecule that can best modulate it so you can actually improve the disease. And then in drug discovery, it's very important to run trials. But a lot of the times we run trials without the right level of diversity and representation, and we're changing that, and I'll share some concrete examples, all the way through actually getting the right access. So when I think about it end to end, let's take the development of trials as an example, and let's take COVID-19. You know, last year when we were working on COVID-19 and developing the vaccine, one thing that was very important is to ensure that it was a global program, representative of the patients and the participants that we need to serve. And we actually developed a machine learning model in partnership with MIT, and Regina was also a very close advisor, so it all comes together in terms of developing that model, which was able to predict 4 or 5 months in advance with about 90% accuracy where the COVID hotspots were going to be. Why is that important? It's taking something that's unpredictable and making it more predictable. And that requires so many data sets that we traditionally use, like where's the disease, where has it tracking it, but also understanding social compliance, because it's the first time in our history where social behavior was a huge factor into how the disease was being transmitted, and then also the policies that were associated with it. And I say this because it's important to know where the disease is going so you can run the trial and develop it very efficiently. Every day counts when you're actually developing a vaccine in a pandemic. But what was really interesting, and this is where the partnership with MIT was fantastic, is we took some of the great machine learning model developed, but then we incorporated diversity. How do we ensure that we actually go to the places where there's more diversity? African American, Latinx in the US, but then also global diversity. And you know, we ended up, and the proof is always in the pudding, we ended up with the most diverse COVID-19 vaccine trial to date. Over 18% African American, which is higher than the census numbers. I'm just saying this is a step, but then how do we scale it across our entire pipeline? So you make medicines faster, you make them better, and you make them ensuring that you have diversity in your trial. So to me, that's a concrete example of how MIT and Janssen use AI for good, right? And then maybe I'll just say one other example with Dina Katabi, and Dina will speak to the tremendous work that she's doing in terms of how do you ensure that you can actually have better digital endpoints, you know, that are less subjective for patients. And I won't go into the detail, but we're working with Dina on this. But the beauty of it is you reduce the burden of actually having to go to a place for a trial. Where is the burden the highest? For those that have tougher socioeconomic challenges. Mm-hmm. So you level the playing field, as I like to call it, and you collect richer data, because it's not going to a physician and seeing them, but it's actually something that's being monitored the entire time. So just a couple of examples of how, I think someone was saying in the video, how do you turn drug discovery on its head? Not just the potential, but already what's happening here.
Thanks. And so to kick that over to you, Regina and Dina, I'd like to hear from your perspective from the science side in your work at MIT, how that has helped, in fact, to further health equity, and how you see some of the work that you've been doing through this partnership leading to, you know, additional improvements, whether for COVID-19 or in the future.
So Regina, do you want to start first, and then I'll take it from there?
Oh, Dina, you go ahead.
Okay. So so basically, I want to go back to one of the points that was raised in Tariq's introduction, which is access to care, access to healthcare. And my interest is really to provide access and to ensure that access is going to be available as much as possible to everyone, and to be really easy and satisfy the need. We are talking about people who are sick, that's like not the average healthy person. So one of the things that we are looking at is how we can make that access in the best possible way. And the innovation that came up with at MIT is something I want you to imagine if you Wi-Fi box at home, the Wi-Fi that we all have, all of the panelists and Miriam, I'm sure you, wherever you are sitting, there is Wi-Fi signal over there. Imagine if that Wi-Fi signal or something very much similar to it, but smarter version of that box can analyze the person breathing, heartbeat, mobility, fatigue, sleep stages, whether they have apnea when they sleep, whether they are getting enough deep sleep versus light sleep, and all of that without touching the patient, just basically ambient health monitoring. And being able to take that information and provide it to the specialist remotely, wherever they are. That actually, it can improve dramatically access to care. And just to give you one context where we use this, I worked with doctors and patients who have Parkinson's disease, which is the second common disease, neurological common disease, and the fastest growing neurological disease in the whole world. And in Parkinson's, similar to many diseases, many specialized diseases, the specialists live or exist in medical centers in certain places. And even in the US, 40% on average, about 40% of Parkinson patients don't get access to neurologists or Parkinson expert. But what we were able to do is by using devices in their homes, completely touchless, monitoring their motion, the disease relevant information, and conveying this back to the Parkinson specialist, and being able to make that accessible to that Parkinson care, making it accessible to those patients, even if they don't live next to a medical center. So that's one vision of what we are doing. And Regina, maybe you can follow up with the stuff that you are doing.
Thank you, Dina. And I just want to say that to me, the main things that AI can bring and is already bringing to medicine is really changing the paradigm from catch up. So today we typically are treated when we already have a condition, and sometimes it's too late to treat the condition, or the treatment is really challenging and painful. So the question is, can we do the same thing that Amazon does for us when we when we're buying stuff online? It can predict what we would like to have and suggest us different things. In medicine today, we have really limited ability to foresee the future and to identify the treatment in the earliest possible stages and personalize it for a patient. And as a result, whenever we today stratify the patient and finding treatments for them, the patterns that are used to kind of do these diagnostics are very, very broad, and then cannot be really personalized because we're using human intuition to subdivide the population. What AI can do, and we've seen it in all different areas, especially in e-commerce, can really in a very precise way kind of identify your personal trajectory. So to me, the vision of AI changing medicine is really to take the patient with all their data, like the data that Dina was describing about the movements of the patients, like the sequencing data, the imaging data, and really predict what's to come next and what is the most effective treatment that the patient can get. And more specifically, when I'm thinking about it in terms of oncological diseases like breast cancer and lung cancer, we have already demonstrated in Jameel Clinic that we can reliably predict the occurrence of future lung cancer and breast cancer up to 5 years in advance, which gives the physician and the patient ability, to identify the best treatment and interfere. And now when we are talking about, making it really equitable, what we know, and it was kind of referenced in the introduction, that many of the current treatment regimes are really developed on the wide population on some parts of the world, and then they're applied to everybody. So one of the key questions for us is how to make sure that all the tools that we are developing here personalized for diverse population, not fitted just for a single population. And one of the key goals of Jameel clinics is to build these big collaborations with parts of the world which typically don't benefit today from AI, and those parts of the world where the need in cure is maybe more acute than here in the United States, is our big questions, really doing the translation, studying how these tools can help, and creating AI that serves all.
Thank you both for that. And I can imagine so many applications of this type of work, in particular, in fact, for places that are very hard to access. But of course, that requires other bits of infrastructure. There has to be the wireless, there has to be the internet. There are still opportunities, of course, to be able to upload data, after, but there still needs to be the infrastructure there that's available. And I wonder, maybe I can go now to Ziad, and then I'd like to also touch base with Edson about this. Ziad, you are doing work, I know in the US, you're working on AI. You're also working with populations that have trouble accessing healthcare for a whole variety of reasons. And we know that this is an issue in many places. And I wondered if, based on what you've heard and you're reflecting on this, what some of your thoughts are about how to take this forward and bring this, excellent science to where it needs to go.
Yeah, let me pick up on some of the themes that both Regina and Dina raised, which is trying to broaden out the data collection activities that we do so that our data speak to the problems of people, not just who are fortunate enough to live in the neighborhood of academic medical centers, but people around the world who as Regina said, are perhaps the most in need of this technology. So there's a statistic that comes from a study last year that of all of the artificial intelligence algorithms that are published and people are thinking about using, I think about 60 or 70% come from Cambridge, Palo Alto, and a couple of other places that have, not to diminish the health needs of people in those places, but they are not representative of the rest of the world. And so, when you're building algorithms in those places, you can only ask and answer a certain set of questions. You can, with some creativity, try to ask those questions in a general way, but it's just not the same as collecting data from different places. And so one way that we're trying to address this problem is via a nonprofit that I co-founded called Nightingale Open Science. We're going to launch this in December publicly. And the goal is to work with health systems that are in particular underfunded in OECD countries, but also around the world, and invest in their data infrastructures. So we're working with one county public health system in the Bay Area to upgrade a lot of their ECG systems, their X-ray systems, so that we can start pulling data out of it, building algorithms that can, for example, diagnose undiagnosed heart attacks that have happened to get people on the right medications, so that we can help triage high-risk pregnancies and get the right women into the hospital and let the other women deliver wherever they want. So I think that by broadening out the data collection, we're starting that chain of value that leads to products that speak to the health needs of people around the world. And I'll just say that there's one other important element here, which is that it's tempting to think that, as hard as it is to broaden out this data collection, that's kind of what we need to do. We need to get diverse populations into algorithms, and all of that is 100% true. But let me take the example of COVID and show how you also need a bunch of other stuff after that. So one of the real dilemmas in forecasting COVID is that the only COVID that we see is the COVID that gets diagnosed. So what does that mean? It means that populations who have access to COVID testing are going to have their epidemics highlighted and more visible than communities who don't have access to testing. And you can think of the problem when you're designing an artificial intelligence algorithm to predict the spread of COVID is we don't see the iceberg underneath the water of all of the COVID that's not diagnosed, which is of course much more common in underserved communities. And so the very thing that we're training our algorithm to predict is biased. So you can get lots more populations into the mix, but until you fix that variable that the algorithm is trying to predict by testing more people and by targeting testing in intelligent ways, your algorithm is just going to reproduce all of the biases that went into the disparities in access to testing to begin with. So it's not just about data collection, it's about crafting the question for algorithms to answer in a way that, that undoes some of these biases that go into the data.
Thank you, and that's really interesting. I wanted to just point out, we always like to say, data are not sexy, but what, gets measured gets done. And you've raised some really important points around what it is that we actually collect. Looks like, Najat, you want to piggyback on that?
Yeah, I was just going to say, because that was such an important point in terms of the amount of underreporting that actually was much, much higher in more of the developing countries. So we're looking at Brazil, Argentina, South Africa, and so forth. And Ziad's point is absolutely right. And what we needed to do was to be able to then model what that underreporting is. So that was actually getting some of the seroprevalence. So it's basically where you go in and you test and see what percentage actually had the disease versus not. So we had to use not just different data sets, but create some prospective data sets to figure out what the gap was. And the beauty of it is after we did the trial, we were able to see what the actual incidence was versus what's reported. And then we actually did some public-private partnerships to share that data back, because it really helps to understand what is that gap, right, in terms of reporting. Where do we see that being more extreme in a country as the country itself thinks about and the state officials think about managing the pandemic? So I couldn't agree more. It's triangulating a lot of different data sets, but investing to actually create new data sets to be able to enhance the algorithms that you have. So just wanted to say it's like a feedback loop and you keep learning from it, but being aware of the limitations up front and using different data sets becomes important.
And AI can really help there too. So there was a paper published yesterday in Nature that describes an algorithm that was implemented at Greek points of entry last summer during the height of the COVID epidemic, when there was a huge premium on keeping the borders open because tourism is so vital to Greece. So researchers working in the US and in Greece deployed a reinforcement learning system to intelligently target testing to incoming passengers at the border. And they found a lot more COVID than they would have had they just been looking at the public statistics from the country that passenger was from. So I think it really nicely illustrates how AI can be a tool for actually targeting these kinds of tests and undoing these sorts of inequalities that lead to disparities in testing to begin with.
This is music to an epidemiologist's ears, I can tell you. I'd like to move now to Edson. You're based in Brazil. You've done some really interesting work in the north of Brazil and in other areas that are challenged in terms of their infrastructure, but yet you are working to bring AI to these other communities. And I wondered if you could try to share your perspective briefly on some of the successes you've had, but also some of the challenges, which I think are really important for our audience to hear about.
Thanks. I'd like to emphasize a few points that were already mentioned, but also to give you the perspective of having the boots on the ground, right? So when you're there, you look at these people that are in underserved populations. So we work in small communities, 11 cities in a very poor area of Brazil. The socioeconomic index is very low. The IDH is something around 0.6, for instance. And over these years, we were able to look at how they perceive technology, including AI. And I think this is really relevant to know that we are social beings. So when we communicate between ourselves in our local community, we comment about these new technologies, how we use those in our daily routine, specifically in healthcare, for instance. When we look at algorithms to predict what is the chance of a certain individual of a community, again, very poor region, to develop complications because he or she doesn't treat the hypertension condition in a way they should, there are all sorts of parameters that are not comparable to highly developed countries. For instance, they don't know exactly what it means to take medication. Sometimes they say medication as if they were saving food for the next day, which is not the case. You are supposed to take medication every day. they'll not save your medication because sometimes you might not have access to medication. So this is actually one example of how far we are from getting in touch with how they perceive technology, how they take into account the advantages of it. And then some questions that we have to ask is about data quality or representativity of a particular parameter to the reality. For instance, death certificates in many countries, we have a lot of garbage coding. And what we did was to an algorithms to predict vice versa. What would be the quality of death certificates in all cities in Brazil? So we have an index of what to expect in that data. So then people can take action upon what's going to come in the future. Because this is actually definitely a huge point in terms of resolving biases when we develop algorithms, exactly what we've been hearing so far. Another point that I would like to emphasize again is digital literacy. So everybody, I mean, I can say that radically, something around 84 to 90% of all Brazilians, they have smartphones. Don't ask me why they are actually so keen on getting smartphones, not because they have the economical condition. It's actually a phenomenon. Social media makes it happen very heavily. And this is actually a privilege from certain coaches. They are very social. So they share the information. So one thing we did was to take into account what could be done if you use an app that pregnant women are using to share their experiences. So based on what they exchange, the text that they are using, and combining those information with specialized nurses. So we promote a condition in which we could test a deep network, and we call it BabeNet, but basically what we did, we tried to predict low birth weight and premature deliveries in this communication based on how they speak about their healthcare situations. Again, this brings into account the idea of once you have limited resources, you really have to work even harder to save money for other applications. For instance, not everybody will need to see a doctor if he or she has a chronic condition. But what can be done in that situation? How do you get a result of an algorithm that can actually tells you which community needs the most urgent care? What is detrimental about this? Are you causing benefits, or sometimes we have false positive in algorithms all the time and false negatives? What are the results of using these tools? How do you take care of when things didn't actually happen the way we predicted? So last thing I want to comment on that, so these are challenging questions and even more important when you don't have health resources. The last thing is about predictive analytics versus prescriptive analytics. How do you prescribe the way you organize your healthcare system, for instance, in northeastern Brazil? Again, looking at pregnant women, high-risk pregnancy, it's a huge problem, and it's very unequal across the country. So how would you organize where you would have the clinics to take care of neonates at high risks? What's the distance? So we had to calculate the traveling distance using the tools that we have today and predict what would be the best organization of nurses, doctors, and how often they should see a doctor, depending on where they live and where they are. So the idea is try to balance the conditions on where you live, so georeferencing conditions together with individual fragilities, for instance, biological risks that one may have, for instance, depending on the weight that these people have to carry over their burden already related to economical conditions, plus socioeconomic, plus access to healthcare. So when you combine all those data in a complex network, we can actually provide a better way to look at the governmental actions toward that population, not as an overall solution. It actually has to be context-based. So I think most of the things that we've been using AI so far is related to context-based solutions, as we've seen so far, and also to increase the efficiency of the lack of resources, I would say, that we have to live with in low to middle income countries.
Well, you've really touched on a number of the other issues that you need to think about when you're bringing in AI, but it makes me think a little bit about your work, again, Dina, and what you were talking about in bringing AI into the home for people to maybe find out early if there's a problem in addition to monitoring. And I wondered if you had some thoughts based on what Edson just shared and how your work could potentially be brought to some of these last mile locations.
When Edson was talking, I was really thinking about that because I think he pointed out to one of the most important problems, which is the efficiency of the healthcare system. We know that healthcare is very expensive, but also many of the expenses are not used in the best way possible. So if you can actually target resources to when they are needed, that would be very, very beneficial for both advanced countries as well as underdeveloped countries. So one of the things that, let me just take chronic conditions, because they are very expensive and much of the resources in the healthcare system goes to chronic conditions. But we know that chronic conditions and exacerbations, say for example, like exacerbation in congestive heart disease, COPD, they don't happen overnight. They build up. And actually, if you are able to see that buildup as it's happening, you can refer the patient and make the healthcare system focuses on the people who are moving toward an exacerbation before actually it happens. And in many cases, there are statistics that many of these exacerbations can be like hospitalization and ER visit can be avoided. The question is, how can you reuse the technology to do that in the most efficient way? And this is one of the things that we focus on. And we see it very much in our results. We see it even we deploy our devices. As I said, our device is very multifunctional because it just sits in the background and it's using a wireless signal that is reflected of the environment to analyze health and vital signs. So we deploy, for example, with Parkinson patients, but we see, for example, the precursor to people entering the hospital because of heart failure, for example, and cardiological problems. So you see that their respiration, their fatigue level, their movement change actually almost like 6-7 days before actually the event happens. And all of that things can be used to avoid actually these hospitalization. And that you can imagine how much of the cost actually goes to these things, but also the outcomes are much worse after the person ended up in the hospital. So technology allows us to rethink how we deal with health problems and focus on prevention and avoiding hospitalization and exacerbation before they happen as much as possible. And we arrange the way we put our resources in the most efficient way. And I want to use Edison's statement, which is like basically the context, being able to operate, understand the context, and focuses on the right context.
Yeah.
Very, very interesting. Yes,
I mean, just
please.
one thing that Dina was saying, and Regina mentioned this earlier too, you know, there's an importance on the algorithms and developing it to diagnose diseases earlier, especially there's some diseases that impact more diverse populations, which quite frankly gets even less diagnosed if you see in the real world today. I think there's also an important point, which is how do you ensure that there's clinical utility on that efficiency point, right? And I think that end-to-end is something that I've also seen over the last few years, the field has been moving towards. So from a really important question, a really important algorithm, to actually deploying it in the real world. And we're doing some of that for, it's a disease called pulmonary hypertension. And one of the goals for us has been, you know, it's a rare disease, so it's not chronic, but it's a rare disease, disproportionately affects women, disproportionately affects women of color, and women in their 30s and 40s. And you know, by the time they actually get diagnosed 5-6 years later, it's too late. There are medicines, but we are not catching it early enough. You know, and the algorithm's great, you develop it, but what we're focusing on right now is how is it actually being used in the world, right? Like how is it, and especially not just in the US, but some of the developing countries, and ensuring it was based on ECGs. ECGs is a device, back to your point on infrastructure, that is fairly common in developed and developing countries. So developing an algorithm that you can add on to an existing workflow, and then seeing how are physicians utilizing it. Are you actually getting the flag that you want to say this person might have a suspicion for a disease? I think that piece is also extremely important because the algorithm, this is back to the reinforcement point that was made earlier, learns from it, right? Because even when you start developing algorithms, sometimes the data sets aren't as diverse as you want. It's a challenge. So I think this sort of feedback loop and ensuring, I think Tariq said in the beginning, that there's clinical utility to get to the efficiency point that both panelists mentioned. That's, I think, where I see we need to even push further, and doing it not just in the US in a nice health system in Cambridge, but doing it in a targeted way across the globe.
It's really fascinating. Yeah. We're going to, yes, we will touch on you, Regina, and then we're going to move to our Q&A section of the program. So please go ahead. Thank you.
I just want to reiterate and say how we translate this idea of actually seeing how AI serves diverse population here in Jameel Clinic at MIT, with all the colleagues who contribute to it. So what we now have in the AI community is a lot of algorithms. All the journals published today have different AI algorithms. Unfortunately, we all know as a patient, very few of these algorithms are really translated and benefit patients and us at the point of care. And in collaboration with Wellcome Trust, we are building the hospital network, which is currently have hospital, in different parts of the world, primarily, in Latin America, in the United States, and we're expanding it further, is where the participating hospitals with serve diverse population can, we help them translate our algorithm that were tested locally to the, to the population, and seeing in reality how these algorithms are really used. And we already can see that some algorithms that are used here in the United States have one point of usage, for instance, like reading images here, where you have, very experienced radiologists who can read all the images. You can just use these tools, for instance, to prioritize who needs to be seen first during the COVID time. On the other hand, in the developing countries where the cost and the number of available doctors is limited, in this case, you can actually rely more on the technology to do reading and screening. So we're just trying to understand what are the different modes this AI technology is used, and whatever mode you would find in one country may definitely not to be translated in another. And it's very important for us not only to do our work in the lab, but I know that Dina also collaborates extremely broadly with the physicians to see what is the physician's view, how the algorithm can help and to different population, and see what are the different scenarios that the tool can be used, because it's not one type utility of AI. There are many different utilities, and developing world will have their own scenarios and mechanisms, and we need to adjust our AI to support it. So I'm really excited about this translational project and want to thank Community Jameel and Wellcome for supporting it.
Thank you very much. And now to kick off the Q&A portion of our discussion, I wanted to bring in our first question from George Onizaforo, who is a research manager at the NHS AI Lab, and he's watching today from London. So hi, George. George tells us that the mission of the NHS AI Lab is to enable the development and production of safe, ethical, and effective AI-driven technologies in the UK health and care system. A particular focus of the lab is how to counter the inequalities that may arise from the ways AI-driven technologies are developed and deployed, especially in healthcare settings with diverse communities. In that context, George would be interested to hear what the panel thinks are some of the clearest successes, but also some of the limitations of AI in improving health outcomes in minority and ethnic populations.
I can maybe just give a first thought on that one, because a lot of my work has dealt with algorithms that go wrong. And so, we have done some work on algorithms that are used to manage the health of populations. This is a big dilemma, both in the US, but especially around the world. There's a population that you have to take care of. You know that some members of the population are going to get sick in the future. For example, as Dina mentioned, they might have an exacerbation of chronic heart failure, COPD, anything else. And you want to figure out who's going to get sick today so that you can help them. So what a lot of algorithms are trained to do is to look ahead into the future, which algorithms are very good at doing, and predict, who's going to get sick. But there's no variable in your data set called getting sick or even health. And so you, as the algorithm designer, need to make a choice about which variable you're going to train that algorithm to predict. And the choice that a lot of algorithm developers made was to predict the costs that a given patient was going to generate. Not an unreasonable choice, because in general, when people get sick, they generate costs. But the problem is that not every sick person generates the same costs, because not every person has the same level of access to the healthcare system. So by training the algorithm to predict, in this case, dollars rather than health, the algorithm had an enormous amount of racial bias that was scaled up to tens of millions of people every year in the US, with similar trends in similar algorithms around the world. So we built on that work. We had a lot of collaborations with a lot of different health systems to audit algorithmic bias in things that they were already using. And we found bias in lots of different places, from clinical algorithms to population health algorithms to operational algorithms used to book clinic visits on the back end of scheduling software. So the amount of bias was just enormous. But critically, that bias could be both diagnosed and fixed. So by retraining those algorithms on variables that were much closer to patients' health rather than their costs or analogies in other settings, I think we have a lot of potential to counter this bias and to turn those algorithms from tools that reinforce structural inequalities into tools that actually fight against them. So even though we found a lot of bias, I think I came away from that work with a lot of optimism that with a lot of thoughtfulness and care in how we build algorithms, we can actually get them to do the things we want them to do.
Sorry, go ahead, Edson.
May I add just one point? The speed of adoption, it's one very often forgotten way to bias the use of technology. So once we have limited resources, those that are able to adopt it, I'm not just mentioning economical issues, as I mentioned, it's the whole context, right? So that can also bring some problems into the community. So the poorest among the poor, this is also a key problem because we have a huge population that really runs very, very, very below the conventional radar that those that have access to at least a hospital are being so far studied. So we know the biases in certain conditions, exactly the ones that you mentioned, but there are another level of bias that, again, I would stress the point that is the speed of adoption, which is, again, treatable, understandable, but has to be taken into account.
Mm-hmm. Yeah, so I want to add one thing, which is basically, take Ziad's example about this algorithm that has a bias because it looks at the cost. But in the vast majority of cases, the bias actually comes from the people, from the people and our load of biases and that we have and how we think about things and where the data is available. In many cases, the algorithms can be an opportunity to fix these biases. Now, of course, there are other biases that could be intrinsic to the algorithm, but the vast majority of cases that I've seen, the bias comes from people. Just to give you an example, so in our data, we measure the actual physiological signals of people. But you see that when a doctor looks at certain people, they say, oh, it's maybe they are exaggerating. A woman exaggerates her pain, for example, as opposed to a man. So, but if you are looking at the actual fundamental physiological signals, it's an opportunity actually to reduce the bias as well. So we have to be careful about also using this opportunity that technology can help us understand our biases, face them, and try to deal with them. And ask ourselves whether we brought in the bias and brought it to the algorithm.
I want to take a question from our audience now, touching also on some of the technological issues. So this person asks, we hear about how cell phones have led to rapid advances in banking in the Global South. Picking up on Edson and Dina's comments, can mobile or wireless technologies lead to a leapfrogging by developing countries to catch up or even overtake global north countries in healthcare outcomes?
I mean, I think that's so possible. If you look at some of the developing countries, and I think someone shared one of the statistics, they're actually more digitally native in some cases, and there's more openness. Like if I look at what's happening when it comes to healthcare in China, or Hong Kong and other areas, and even in Singapore, it's highly developed, right? Some of the ways that COVID was actually managed was far more progressive. So I do think there's an opportunity. It's what happened with credit cards, right? There's no cash and checks in between to really be able to leapfrog. But I think some of the challenges that remain is around data and how the infrastructure point and how are the data sets collected and QCing it and ensuring that there's the right amount of privacy. So I think there's almost a separate challenge to really focus on to ensure those aspects are done well. But I do think it gives a wonderful opportunity. I'll give you an example. Like as part of our global public health program in Rwanda, we actually have, in terms of the vaccination status, used more digital tools such as retinal imaging, and the adherence is extremely high. And you know, in order to deploy that in the U.S. has been a little bit more challenging. So there is a lot more openness, but then it also needs to be underscored by some of the data challenges that still exist. But I think it's a great opportunity.
I want to take another question from the audience now. Billy, a biochemist who joins us from London, asked, to what extent are there collaborations with private sector AI development, given that technologies such as AlphaFold, indirectly developed by Google, promise to solve enormous biochemical mysteries?
So if I may take this question, sorry, regarding the collaboration related to drug discovery, and I would say that in this particular area, there were really a great success of combining, you know, academic research and private funding. For instance, MIT's Jameel Clinic collaborates with a large number of pharmaceutical companies, including Janssen, in developing tools that really speed up drug discovery, like screening of the molecules for their properties, designing new molecules, identifying side effects, and utilizing technologies like AlphaFold to really kind of model the binding between the targets and the molecules. And we, on one hand, we already see concrete successes like a drug, halicin, which is a new antibiotic, which has a very strong antibacterial profile, was developed using this tool at MIT. On the other hand, we see that the pharmaceutical companies, maybe Najat can speak to that, really implemented in a wide range of the companies. So in this case, it's really important to build a partnership because we have a lot of knowledge and strengths in algorithms, while the pharmaceutical companies really understand well the biological and clinical problems. So bringing the two pieces of expertise together and finding the right funding mechanism is really essential here.
Najat, would you like to respond
Yes,
to that?
no, I couldn't agree more. I mean, you know, especially, I mean, at J&J, we always think about innovation. We're very agnostic, internal or external. And I think that helps a lot, especially in a space like data science and AI, which is rapidly evolving. To Regina's point, you know, some of the approaches that her team is using, it's very different from what's been done in healthcare before. But in order to actually have a pull-through in healthcare, it's important to understand the regulatory considerations, the patient consideration, the clinical utility. So it's a really good, I think, collaboration to then take it to translation. Again, I can't emphasize that point enough, because what we don't want to do is have a pile of algorithms that's actually not helping the patient at the end of the day. And I think working together can really do that. So academic institutions, consortiums, and then pharma companies and other life science companies as well.
We have time for one more question and a very, very brief comment from one person. And this is something that might be on others' minds, and that has to do with data privacy. What, if anything, is being done now to create perhaps a roadmap going forward to look at how to tackle some of the privacy issues which one can imagine would come up in these discussions?
I'll just quickly comment on that. So open banking, it actually reminds of the previous question. So what is the difference, or what are the benefits from translating solutions from one sector of society to healthcare? So open banking, I think it's one good example of that. So why people are afraid of sharing their healthcare data, where in a situation in which they have the tools to share their income resources. In any situation where we believe that there is a benefit for the society, it has also to be translated directly in a daily routine, I think. So when we look at the digital questions related to data privacy, or even cybersecurity for that matter, these are questions that I think are solved in many conditions. But in healthcare, when you take into account what are the benefits for sharing my data, it's not that clear, I might think. So it has to be something that goes directly to people's life, and it's a must. We have to work on open science, definitely. There are some efforts ongoing, but we should actually tell people why that's the case. So I think that there's a need for us to explain to them exactly what's the value of sharing their own data. So most societies that are now working in technology, they're still in the situation where it's opt in and not opt out. And this, of course, is a question of ethical dimensions, but I think we should emphasize the value of sharing data.
Thank you so much. And I want to thank all the panelists. You know, at the Lancet, we're almost a 200-year-old journal in 2023. And we've certainly found that we really have to be, you know, targeted in terms of thinking about what is happening on the cutting edge. And we now have the Lancet Digital Health, which is also a journal in this area. Because, and we didn't have time for this question either, but you know, how all this work you're doing gets disseminated becomes very important and needs to be disseminated in a way, not just on the medical journal side, but in so many different avenues, in a way that people can understand and feel that it's truly impacting their lives in a positive way all over. And so I would like to thank everybody again, our panelists and Community Jameel and the MIT Abdul Latif Jameel Clinic for Machine Learning in Health, the Jameel Clinic, and welcome, along with freuds, and the incredible staff in multiple time zones and here in New York who put this event together. So please join me in thanking them very much for everything and a wonderful event today. Thank you.